Hello, dear listeners, dear candidates of European Diploma Anesthesia and Intensive Care. My name is Andrzej Wawinski. I'm one of the consultant anesthetists at Torbay Hospital in southwest of England. I'm also an immediate past EDAC examination committee chair. And today is my privilege and a pleasure to talk to you about anesthesia for ENT and maxillofacial surgery, including pediatric anesthesia. Okay, let's talk about ENT anesthesia. What does it entail? And what are the problems associated with it, and what are the techniques? So when we're dealing with ENT, as you know, stands for ear, nose, and throat. When we're dealing with ear, there is no airway competition between us and surgeons. But when we're dealing with nose, quite often there is, I would say 50-50% to up to 100% airway competition between us and the operating surgeons. But when we're dealing with the throat, it's almost always 100% airway competition. And that's what we need to bear in mind mainly. Let's talk about the range of ENT operations. There are many of them. The most widespread ones are adenoidectomy, tonsillectomy, extractions of foreign bodies, particularly in children. Then there is laser surgery to the larynx, and endoscopic diagnostic procedures to diagnose cancer or benign tumors. And then there is septoplasty for cosmetic reasons and for trauma reasons, to put the and also there is something called functional endoscopic sinus surgery. But there is a laryngectomy for malignancies. There it is functional endoscopic sinus surgery for a functional treatment of breathing associated with obstructive sleep apnea and others. Also, there is a uvulectomy for obstructive sleep apnea, and they perform tracheostomies and many other procedures. This is not the exhaustive list. How can we secure the airway? We can do it with many different ways. We can put the traditional tracheal tube. Sometimes it is possible. However, the surgeon needs an access better than just with a normal endotracheal tube. So quite often we go for something called microlaryngeal tube. And here's the difference here on the screen. You can see that for the same size, 6, there is a standard tube at the bottom of the picture, and the microlaryngeal tube, MLT, is at the top. And you can see that the length of the cuff is the main difference. And the length of the cuff is longer, so it's the high volume, low pressure type of cuff. And also the distance between the cuff and the tip is longer with the microlaryngeal tube. All that is designed to give a better access to the airway for the surgeon. And then there are laser resistance tubes, then there are metal type tubes. Norton is the only one that is still available on the market. Then there is laryngectomy tube or J tube. There are tubes with nerve conduction monitoring. And there are different types of catheters, something called Mon-Jet tube or Hansaka catheter. There is Monsoon catheter, and there is an innovative tri-tube catheter that we will speak about. And there is a flexible laryngeal mask. Indeed, for a lot of operation in ENT, you don't need to intubate. You don't need to pass the tube past the vocal cords. You can do lots of different procedures with a laryngeal mask, and the flexible laryngeal mask is the best one for these purposes. Okay, and then indeed there's open airway, no tubes at all, using something called OptiFlow, a high flow humidified oxygen. You need to be aware that if the smaller the tube, the higher the peak airway pressure will be. And on this particular screen, you can see that the peak airway pressure in this patient's airway is up to 44, delivering tidal volume of only 300 mils. But you can see at the bottom the IE ratio in expiratory ratio is 1:6, so you need a lot of pressure, sometimes particularly in partially obstructed airway or in narrowed airway, to deliver your tidal volume. So laser resistance tube, we mentioned, there were lots of them on the market. The Sheridan red rubber tube with a cuff and rubbed with copper and fabric. And then some of them were rubbed with a protective aluminium metal foil, silicone. And then there were Mallinckrodt laser flex stainless steel tubes rubbed with the PVC, all that to prevent fire in the airway. Obviously, if you have put a metal tube, then that tube cannot ignite at all. And the matte surface reflects the laser, but it's quite thick, and that tube. So although to achieve a good internal diameter, the external diameter will be very large. And very often, almost always, the stiletto will be required to pass this tube through the vocal cords. So they're not very popular, the tubes, and obviously they don't have a cuff, so they don't provide the sealed airway. This is the J tube. This is an example of if you need to do something for the reconstruction of the larynx, the first thing you would do, instead of using the normal tracheostomy tube, which is inconvenient for the surgeon to operate around, the J tube, whether just a J tube or a reinforced J tube, like in the middle, could be used. Then there are tubes with a nerve conduction monitoring. These tubes are particularly useful on the patient undergoing mastoidectomy, where the surgeon is working closely with the facial nerve, and in order to avoid damage of the facial nerve, we use nerve conduction monitoring, so the surgeon can always be sure that they are not damaging the facial nerve. Otherwise, the patient may end up with a palsy, or facial nerve palsy, which could be devastating for their life afterwards. Obviously, the patient does not need to be paralyzed with a very short-acting muscle relaxants. Then there are several types of catheters. This is the proper name of this catheter is Monjet tube. However, everyone refers to it as a Hansacker tube by name of the inventor, which was introduced something like nearly 20, 30 even years ago. It's got a basket and this tube and a stiletto. It's okay to put it in, but it's not a laser-proof tube. So obviously this tube will be used in conjunction with the different types of jet ventilators, not a laser-proof tube. Now, there is a monsoon jet ventilation catheter that appeared later on in conjunction with a monsoon jet ventilator. That is a laser-proof tube, and let's have a look at it. It has the opening for the CO2 and airway pressure measurement. It has a stiletto to put it in. It has a laser-resistant Teflon coating. So this tube you can use for any operation involving laser. And there is a lower lock connection with a lumen for the CO2 and airway measurement. So that is the major advantage of this tube. We can measure CO2, not so accurately like with a normal tube, but still. But most importantly, we can measure the airway pressure, because particularly with the jet ventilation, where the inspiration active but expiration is passive, it is very, very important not to allow the build-up of the excessive pressure that can cause a pneumothorax. And that is a tri-tube. This is the latest invention that comes together with a machine called Yvonne that we will touch upon a little later. And this tri-tube, as you can see, has 3 lumens. There is a cuff as well. So there is a lumen for the cuff, there is a pressure lumen, and there is a ventilation lumen. And that you can see the difference between the conventional tubes and this tube. And it's only 4.4 millimeters external diameter and only less than 3 millimeters of internal diameter. So you can see that a passive expiration will not be possible through that tube. So that needs a very clever mode that provides an active expiration. And there's only one machine in the world that can do that. I'll show you later. Here it is in the close image, this tri-tube produced by Ventinova with those 3 lumens that I mentioned and the stiletto, so you can pre-shape it if it's a difficult airway using your hyperangulated video laryngoscopic plate. Here it is, malleable stylet. And you can see this tube provides, like many other catheters, provides a very good visualization of the larynx for the surgeon. You can see how the surgeon made this airway from obstructed by tumor to a reasonably opened airway at the end of the procedure. And then there is a flexible laryngeal mask. I want to stress that not just the normal laryngeal mask, classic LMA, but the flexible laryngeal mask that obviously will keep the lumen patent, even if it's tied into a knot, like on this picture. So we can position this tube down the patient's jaw, up and fix it along the bridge of the nose, whichever way you like, to give the surgeon good access and to continue for this patient to either breathe spontaneously or being ventilated. And then there's indeed an open airway that I mentioned, and here you can see on the left a device called OptiFlow that is providing an oxygen up to 70 liters per minute, which is humidified and warmed through a nasal cannulus, and that method can not only oxygenate patients really well, but also provided some degree of CO2 removal. And patient could be apneic certainly up to 30 minutes without any harm. But in the original paper assessing this method by Patil and Naray, they mentioned patients being apneic for up to an hour. Methods of ventilation, let's speak about those. There is a spontaneous breathing that for some operations is possible. There is the traditional intermittent positive pressure ventilation mode that we can use. There is an apneic intermittent ventilation that I will show you. And then there is jet ventilation, and that could be supraglottic, epiglottic, subglottic, transtracheal. It depends where you put your catheter. That jet ventilation could be of low frequency or high frequency. And indeed, we can do without ventilation based on the principle of apneic oxygenation. This is the traditional intermittent positive pressure ventilation through the side port of the or the microlaryngeal tube, side port of the bronchoscope. And you can see here the rigid bronchoscope is prepared for airway evaluation. And there we have an adapter to connect the ventilation to the circuit of a anesthetic machine. So we can then ventilate either through the machine or manually by squeezing the bag. And here's the apneic intermittent ventilation. You can see here the hanging laryngoscope, the ENT type laryngoscope through which the surgeon operates. And then the tube can put in, give few breaths, oxygenate patient, then the tube comes out. Surgeon does part of the procedure, and it's apneic period without supplying any oxygen, and then tube goes back in. This is in the days where no intravenous and total intravenous anesthesia was available, and the only way of keeping the patient asleep was by giving them inhalational agent. Obviously, this is of historic importance. Very few anesthesian surgeons apply this method these days. There is a Sanders injector or VBM manual jet. Both of them, they're very similar. Sanders injector has been around for ages and ages. They both have source of oxygen, of high pressured oxygen, up to 4 atmospheres, 4 bar, that standard oxygen supply provide. They have a regulator that can regulate the pressure. They have a lever that we press on to initiate the breath in. With the manual jet, the only advance from the Sanders injector from the Sanders injector is that it gives you a guidance on the screen where to put your pressure depending on the age and on the weight of your patient, and also you can lock that pressure so you do not accidentally exceed it in order not to produce pneumothorax. But it's a very crude device, and obviously can only inject air under the pressure into the patient airway. It cannot provide expiration. The patient will rely, you and the patient will rely on a possibility of passive expiration. So there has to be a lumen. You cannot use it in a totally obstructed airway. There is this Klein-Sasser technique with a subglottic catheter. You can see how it's used. I don't think there is a sound, but if there was a sound, you could hear the hissing going there on this video. You can see through the laryngoscope that we are delivering jet ventilation through the catheter that is goes through the vocal cords and placed subglottically, and then we can ventilate. And on the scheme on the left, you can see where the catheter goes, where this jet ventilation catheter goes. This is a very well recognized technique and used by many specialists across the world. The same principle can be transtracheal jet ventilator, where we put the catheter through the cracroid membrane using different types of cannulas and connect it to the jet ventilator. The devices, as we mentioned, consist of Venturi pressure devices like Sondas, VBM Manujet, or pressure devices, Venturi pressure devices, or Venturi flow devices. And among flow devices, we have Ventrain, which I will show you, and Evon. We also can use a high frequency jet ventilation like Monsoon. There aren't many types of ventilators, unlike the traditional ventilators on the market. So most of them I'm mentioning in my presentation. This is Monsoon jet ventilator. It has an ability of stopping the gas supply when the specified pressure is exceeded. So it measures the pressure in the airway, and it will cease it if that airway pressure will be exceeded. It has a function of the FiO2 reduction in the laser mode, so you can press the button, and the surgeon says, I'm about to start lasering. You press the button, and from whatever FiO2, it will drop it to 21. You could warm and moisturize your gases, and the frequency ranges from between 12 to 150 per minute. What is the difference? Let's touch upon this. What is the difference between the conventional ventilation and high frequency jet ventilation? With a conventional ventilation, the gas flow is fairly slow. It's bidirectional and it's sequential. Inspiration, expiratory pause, expiration, expiratory pause. There is a issue of dead space with a conventional ventilator, and airway sealing is mandatory. You cannot effectively ventilate without the cuff being inflated and providing the seal. The jet ventilation is different. It's high velocity insufflation of gas through a very narrow nozzle into the open airway. So gas flows fast, it's coaxial, it's partially simultaneous, and it's only going in. And then dead space is less relevant, and you cannot seal the airway because, as I said, you need a passive expiration for what you have delivered being exhaled. So it can only be possible in a not obstructive or at least partially open airway. So there has to be a lumen for that volume that you have delivered through the jet ventilator to be exhaled passively, and it has to be enough time for that volume to be exhaled. And quite often, using this method, the volumes are small. So what are the advantages and disadvantages of the jet ventilation? There is no endotracheal tube, so there's a better view for the surgeon, better access. They can excise better, more tissues if in case of cancer, for example. There is lower risk of ignition if you're using the laser, as lower inspiratory pressure. There is effective excretion of bronchopulmonary secretions. There's fewer problems if your patient wants to breathe spontaneously over that catheter. So you don't necessarily need to paralyze them. But there are disadvantages. There is no airtight sealing, so there is a risk of the aspiration in case of the full stomach. You cannot use it with inhalational anesthesia, so the only technique you will be using with the jet ventilation is obviously total intravenous anesthesia. Setting parameters could be difficult to measure that parameters, so it's more difficult to assess how much you deliver in terms of tidal volume, minute volume, and what is your CO2 elimination. It could be inadequate gas exchange, and there could be a vibration of laryngeal structure, particularly at low amplitude. That's why with the jet ventilation, we quite often use high frequency jet ventilation. So we have this kind of situation of the quiet lungs. When the lungs are not going up and down, they are kind of oscillating like this. So it's actually better for the surgeon, less movement of the tissues. And there is a risk associated with it, like hypothermia, mucosal injury, pneumothorax, and subcutaneous or mediastinal emphysema. And there's hypercapnia, especially in obese, if you're unable to deliver enough minute volume. I've mentioned to you about this device called Ventrain, and that is the flow control device, manually controlled device for providing jet ventilation. The source of oxygen here is at 1 atmosphere, so you're connected to a normal source of oxygen, which you will find anywhere, so you don't need Sundus injectors or manual jet, and you don't need to connect it to the higher pressure source of oxygen. It works with a flow of 15 liters per minute, which is the maximum one can use. There's a lot lower risk of barotrauma because you're only using 1 atmosphere. And most importantly, it provides active expiration. With a gas flow of 15 liters per minute, you will deliver a minute volume up to about 7 liters per minute, which is enough for any adult. And if you occlude both buttons, both holes on the device for 2 seconds, you will deliver with this particular gas flow a little volume of about half a liter. There's a small cannula with internal diameter of 2 millimeters, and it's provide active expiration. Let's see how it works. So I've created a simulated lungs. So this is a bag, a rubber bag. Put the cannula through. So this is completely closed airway, obstructed airways in a way. So there are 2 holes there. So if I'm obstructing both holes, oxygen goes in, that's inspiration. If I obstruct 1 hole, then this is expiration. If I release both holes, then that is the expiratory pause. There's no movement. So by having inside of it a small narrowing, that will this device will provide Bernoulli by Bernoulli principle will provide Venturi effect and will suck out the volume that was delivered with the previous inspiration. So it not only provides active inspiration, but active expiration, as you can see, because this is completely closed airway on this particular model. Okay, so that is Ventrain. Yvonne is the automatic version of the Ventrain that is using this new mode of ventilation, new and unique flow control type ventilation and jet ventilation as well. So if you're using the tri-tube that comes with it, you can use actually a conventional tube, not just the tri-tube. You can use other jet ventilation catheters. So you can use different types of tubes, but if you're using the tri-tube with the cuff, then you will control it you will use it via the flow control type ventilation mode, where again, you will provide active inspiration, active expiration. The machine will monitor tracheal pressure, peak pressure control, PEEP control, and also, as you can see here, there is this little device. This is the mainstream capnography. So you will have a normal capnographic line like with any conventional type ventilator. So, methods of anesthesia for ENT surgery. We quite often use hypertensive anesthesia, particularly for the middle ear surgery, where the surgeon would like a bloodless field. Inhalational anesthesia is still used, particularly in pediatrics. One can use total intravenous anesthesia with a propofol combined usually with remifentanil. And we can use something called Strive High. I'll talk to you a little bit about that in more details. So Strive High stands for spontaneous respiration using intravenous anesthesia and high flow nasal oxygen that maintains oxygenation and patient patency during management of obstructive airway. And this is the paper I'm using from a department in Brisbane, Australia, which has published a series of cases where they use this method. And it uses the OptiFlow or other type of high flow humidified oxygen devices. They used glycopyrrolate, metoclopramide, with lidocaine, a spray on the vocal cords, TCI propofol, and high flow oxygen. Here it is. This is the picture I've shown you already. They spray lidocaine with phenylephrine on epiglottis vocal cords, subglottic space. They use remifentanil infusion, and they using laser. And this is completely obstructed airway. This patient is having oxygen and not breathing spontaneously at all. And that, as I said, can be lasting, depending on the patient's size, up to about 1 hour, which is quite often enough. And then when the surgery is finished and the airway made patent, then they converted that to laryngeal mask, let the patient breathe spontaneously, woke them up. Let's talk a little bit about lasers. I'm sure most of you know that laser is not a word, it's the abbreviation of 5 letters. It stands for light amplification by the simulated emission of radiation. And there are different types of lasers on the market. Here they are: the helium, neon, argon, carbon dioxide, ruby, ND-YAG, and KTP type lasers. They all have different wavelengths and different color. And we need to do different things when we are protecting ourselves from the effect of those lasers. And what can they do to us? They can damage our eyes, they can damage airway, cause burns and skin burns. Toxic fumes that are there, gas embolism. So you can see different types of glasses that are unique for different types of lasers. So when you're working with a laser in theater, you cannot just put any glasses. There aren't any universal glasses. There are lasers for particular types of glasses for particular types of lasers. So the whole team should be aware. There should be the theater should be clearly marked where the laser is used. One cannot enter theater when the laser is used without knocking, without stopping lasering, and we're all wearing particular goggles. So laser, there is a risk of fire when we're lasering. And if we're using the PVC type tubes, then there's always the risk of fire. Let's talk a little bit about fire in the airway. Here's my surgeon using the laser. My tube is at the bottom of the screen. You can't quite see it. And he's using, you can see the fumes being produced. And I'm using laser resistant type of catheter on this occasion. So there is a whole, lots of societies produced recommendations for us. And this is the American guidelines, practice advisory for prevention and management of operational room fires by a task force of the American Society of Anesthesiology. This is a very, very busy slide, and I'll leave you to read it later on after the presentation when you're watching it again. But at the moment, I'd like to concentrate just on when not on the prevention and not on the what's happening later on, but what to do when the fire happens in the airway. And that is the one that was in the red circle, and let's enlarge it. So what do? We remove. That is important. We remove, no matter how terrible this sounds. You don't want to lose the airway, but you have to remove that tube that caught fire. You have to stop all gas flow, remove all flammable materials from the airway. It could be surgical swabs and things. You need to irrigate with saline or water, and if the fire persists, then you need to do use the CO2 fire extinguisher in this airway. Okay. After you've successfully put the fire down, you need to reintubate, do bronchoscopy to assess the damage, and then use IPPV with a low FiO2. The fire prevention, what can we do to prevent the fire from happening? We use the endotracheal tube with a cuff filled with dye. So if the cuff is damaged by laser, the dye will tell us, that will show us in the airway that the cuff is damaged. We need to stop laser and we need to replace this tube. And the dye obviously is liquid, so it will hopefully put down the fire. We use laser resistance and tracheal tubes, and before we use the laser, we notify everybody. We turn the nitrous oxide. Remember, nitrous oxide is flammable, and we'll lower our FiO2 to 21%. Let's talk about the airway foreign bodies. This mainly in children. They swallow all sorts of small objects, and there are a couple of methods of extracting foreign bodies. We can either use the flexible bronchoscope with the basket that we can put at the end of the catheter to the tip of the scope, and then grab it with a basket. Like in this particular case on the left side, it's the peanut. Or we can use a rigid bronchoscopy for the foreign body removal using forceps through the lumen of the rigid bronchoscope. What's the choice of anesthesia? You can see on this picture on the right, different types of foreign bodies in the airway. The choice of anesthesia could be different. You could use intravenous or inhalational technique, but I always advise you to use glycopyrrolate to dry the secretions, and use dexamethasone to reduce the swelling. On this occasion, analgesia, again, remifentanil is the best, but one can successfully use alfentanil or fentanyl in the absence of remifentanil. For maintenance, you can either use sevoflurane via the side port. However, my preferred technique will still be intravenous anesthesia, total intravenous anesthesia, spontaneously breathing, or IPPV. Again, there are situations where one is better than the other. Paralyzed or not paralyzed, again, very, very variable depending on the circumstances. But I would always advise you to use the local anesthetic spray on the vocal cords. Let's talk about the maxillofacial surgery. This is oncopathology for oral maxillofacial trauma, gunshot wounds, infection, extraction of teeth, restorative surgery. This is the most widespread type of tumors that are associated with the maxillofacial SCC, squamous cell carcinoma. The surgical task is this. They need to radically excise the tumor, which is the top picture. Then they need to mobilize the skin to make a flap, and then they need to replace the defect with a skin flap. That's three different type of a surgical etaps, surgical stages. And anesthesia also dependent on the surgical state. When they're doing the radical resection, it's painful. We need more analgesia. So again, remifentanil makes a perfect choice. But quite often I use morphine to start with, give them the loading dose of morphine, and then I use, because this operation is quite long, and they're not going to wake up pretty quick, or they can make up pretty good, but they're not going to go home. So using the long-lasting opioids for this particular surgery is not a problem usually. And then after I've used my, say, 10 milligrams of morphine, I then use remifentanil infusion to kind of top it up. And I use a lot of less remifentanil than I would have without the morphine. Anesthesia principles, there are several problems there. There's both airway, and the airway is quite often the operating field. Quite often these people smoke, drink, they are obese, so they have lots of concomitant pathology, ischemic heart disease, heart pressure, diabetes, you name it. Operations are long. And you need a thorough preoperative assessment, because most often this is the elective type of operation. So you have time to thoroughly have a preoperative assessment, admit them to the hospital on the day of surgery. That's what we normally do. They don't come in a night before. We use a very small, usually sedative premedication, but we give them painkillers. Apart from lorazepam, we use 2 large cannulas. Be mindful of a flap on the harvesting side, obviously. So if you're using this hand, then don't put any catheters in it. Confirm with the surgeon from which hand they are, from which arm, if they're using the arm, not latissimus dorsi flap, for example, that you will not be in conflict with them. Intraoperatively, maintenance could be with sevoflurane or desflurane or Tiva. Desflurane has been withdrawn from many countries now, so sevoflurane is the only one left. And I quite often induce them with propofol and remifentanil. Then I use with 50 ml syringe in the anesthetic room. Then we use our propofol and transfer, take them to theater. And then for the remaining of the surgery, I switch to sevoflurane, because otherwise I'll be changing for the next 10, 12 hours. I'll be changing the syringes constantly. Or the other technique is to use 2% propofol rather than 1% propofol, like they do in intensive care. So you will be using a lot less volume of propofol. Remifentanil, I call it the king of analgesia, but I remember when you finish, they will need something else, because it's quite difficult to provide regional anesthesia and local anesthesia for these cases. But when you switch off your remifentanil, it will get metabolized very quickly, and in 5 minutes you'll have absolutely nothing on board. And if you've not loaded your patient with non-opioid type of analgesics, propofol, I wouldn't use non-steroidals, or ketamine or lidocaine or magnesium, then they'll be in a lot of pain. So quite often they will need fentanyl for a post-operative period, or morphine, like I told you before. Use dexamethasone every 8 hours. Use ondansetron as antiemetic. Dexamethasone, as you know, not just the antiemetic, it also reduces by about 20% morphine requirements. Confirmed by many studies. Post-operatively, use blood gases and hemoglobin levels every 3 to 4 hours. Most often they be getting transferred to intensive care for the first couple of days for observation. Quite often they have a tracheostomy performed electively, like on the picture on the bottom. But if you were using nasal tube before, then convert it to an oral tube, because sectioning through a long nasal tube in intensive care is a lot trickier than through an oral tube. And then quite often we would then put the small feeding tube into the jejunum. And this is my preferred tube for most of the cancer of the oral maxillofacial area. This is so-called polar endotracheal tube. And I put it up, it goes up, it's not facing type of tube, and be aware that it doesn't damage the external nose, because well, this one is a lot better than many others like reinforced tubes, but it can still cause some pressure and necrosis later on. So protect your nose or patient nose. There's quite often a need for awake fiber optic intubation for these patients, because their airway could be disfigured and abnormal. So make sure you know how to use the fiber optic intubation, that you have all the provisions in the hospitals. There is no time for me to talk to you about fiber optic intubation. But make sure that you provide temperature control before you start an operation, because patients cool down really, really quickly. However, it takes ages for them to warm up later on. And the temperature in operation theaters should be within this range, 22 to 24. And as I said, it takes no time, 30 minutes for a naked patient to cool down below 35, and then a long time for them to warm up again. Temperature monitoring, you can monitor temperature very effectively through a urinary catheter with a temperature sensor like this. So there are specific catheters that you can connect to a temperature monitoring. That's what I like. Then there's a skin temperature sensor. Some of them are better than the others. Quite often, when the skin gets sweaty and warm, they will get disconnected and will give you falsely readings. Then there is a nasopharyngeal sensor, and you will aim in for a difference with less than 1 degree Celsius between core and peripheral temperature. If it's less, then your patient is warm and well perfused. Fluid management, crystalloids, make sure that you do not use so-called normal saline, but go for ringalactate, because of a less chance of a hypochloremic acidosis. You would use 10 to 20 mils per kilogram to compensate for preoperative losses, and then 4 to 8 mils per kilogram per hour to compensate for invisible losses. Ask yourself, are the crystalloids really necessary? What are you trying to achieve by giving them crystalloids, apart from submitting them to additional risk of anaphylactic reactions? Blood, usually after surgery, and the thresholds are quite low these days. And actually, if you look at this graph, hematocrit of 30 is better for the perfusion, better for the flap perfusion. And the graph shows that the higher the hematocrit, the lower the velocity. Obviously, this will then reduce the perfusion of the flap. As long as your hemoglobin is above 70 grams per liter, or 7 grams per deciliter, whichever unit you use, and with ischemic heart disease more than 90, you don't need, this patient doesn't need blood transfusion. Anesthesia principle, other considerations: make sure you use some form of prevention of deep venous thrombosis, whether it's floatrons or TET stockings. You use something to cover your eyes or patient's eyes to prevent them from exposure to a dry air of the operating theaters that will then cause corneal abrasions. And you use something to put their heels on to prevent the heels from contact with hard surface of the table and necrosis of the heels. We're going to finish with a pediatric ENT anesthesia, and main spectrum of procedures is there undoubtedly adenoidectomy and tonsillectomy. And there are, according to the UK surveys, there are about more than 25,000 tonsillectomies per year, and 6,500 adenoidectomies. Quite often these procedures are performed together. And then there is a removal of the foreign body that I mentioned. However, children quite often having different types of ear surgery, ranging from myringotomy to myringoplasty to tympanoplasty to mastoidectomy, and they could be children with syndromal children, with Treacher-Collins syndrome, with other syndromes, and they quite often will end up with something called BAHA, bone-anchored hearing aid, that it has several stages to perform. Children obviously will have esophagoscopies in case of cancer, and complex airway reconstructive surgery. This is for children born with the congenital abnormalities of their airway, and they are having repeated surgeries to reconstruct their trachea, and that is done in the specialized pediatric centers. So main considerations: there's airway management. For children, there is a provision of analgesia, and then there's provision of prevention of postoperative nausea and vomiting. In airway management for ENT surgery, there is a choice between flexible laryngeal mask and endotracheal tube, and this is the specific endotracheal tube called RAE, R-A-E. This is abbreviation of three surnames of anesthetists who came up with this particular shape of the endotracheal tube. And you can see this one is cuffless. So in different countries, there are different recommendation of from when the cuff tube could be used. I think in the UK it's still 6 years, so below 6 years, it's sort of recommended to use cuffless tube. We won't go into details about that. There is lots of controversy around that. There are disadvantages and advantages of both. So the advantages of LMA is your straightforward airway, no soiling, smooth emergence, paralysis not required. However, the endotracheal tube will have more secure airway, good surgical access. There are disadvantages of the flexible MA. It may impair surgical access, but for tonsillectomies and adenoidectomies, it's perfectly okay to use a flexible laryngeal mask. Provision of analgesia preoperatively, paracetamol, non-steroidals. I will warn you against the ketorolac that's been associated with the increased bleeding. So paracetamol is your friend. If they reduce to swallow, give them paracetamol intravenously before the start of the surgery, after the induction to anesthesia. Intraoperatively, fentanyl, 1 microgram per kilogram. Avoid long-lasting opioid due to higher risk of PONV. Use dexamethasone again for three reasons actually: for pain relief, for nausea and vomiting, and for reducing swelling. So dexamethasone is your friend. This is the new UK preparation. It used to be 4 milligram per mil. Now it's 3.3 milligram per mil, but it's equipotent. So it's the same as it used to be for. You might come across this particular type of dexamethasone. And postoperatively, regular paracetamol plus NSAID, good old ibuprofen in a suspension will do very nicely for a small late type case procedures, which are mostly in pediatric ENT surgery. So the prevention of PONV, the incidence after tonsillectomy could be very, very high. And before you grab your medication, consider other things. Minimize starvation. We now require 6 hours with no food, 4 hours for breast milk, and 2 hours for fluids. However, for lots and lots of cases, lots of hospitals, including ours, there is no restrictions on fluids now. They can drink up to the time they go to theater. Balanced analgesia reduces the post-PONV, and intravenous fluid administration. So make sure you give them fluids, because that's been shown to reduce nausea and vomiting. Avoid nitrous oxide by all means, because that is one of the very recognized side effects of nitrous oxide. To be honest, we in our trust and many other neighbors trust withdraw nitrous oxide completely from our armamentarium. We don't use it for anything. Perhaps, and you can see this is the picture from my trust, which says no nitrous oxide supply. We only have it in cylinders for a very narrow indication for induction in children in conjunction with sevoflurane. Prophylactic administration of antiemetics, again, the safest ones are ondansetron and dexamethasone. There are many others, but these are the two that are the safest among them all. Just remember, don't give ondansetron intravenously awake, because it burns like hell in the perineal area. Choice of anesthetic technique is either intravenous or inhalation anesthesia and sevoflurane that is used here. And the reason I put this picture is for you to be aware that it is always better to ask the parent to hold the child, and for you to come like this colleague here is doing. They came behind child's back, they're holding their head, and they put in the mask. So you are just controlling the airway, not the hold. It's the parent that is holding the child, helping you. Destruction technique helps a lot. You put the child on the trolley or on the operation theater, they're scared, the parent is not there. It's better to induce them like this on the patient's lap, sitting, and perhaps with the play nurse distracting them with their choice of game on the iPad. That's what we do. And then you can maintain it with other sevoflurane and propofol, depending on the size and the age of the child. Again, remifentanil is your best friend, but fentanyl can be effectively used, which we use lots of time. I wish you success with your examination. I'm finishing my presentation. At the bottom there, you can see the link to the YouTube channel that I maintain. And on this YouTube channel, through this particular link, you will find a playlist with different mock type exams that I have created. There are 3 videos there that are giving you an example of a viva practice for part 2 of the European Diploma on Anesthesia and Intensive Care. If you're unsuccessful of clicking on this link, then just go on YouTube, put my surname there in a YouTube search. My educational YouTube channel will come up, and you will see 60 plus different videos in mixture of English, Russian, and Ukrainian language. But all the exam 3 videos for exam are all in English, and it gives you an example of excellent performance, good performance, and borderline performance, which is very important. So again, good luck with your exam. I hope you all prepare and successfully pass. Thank you very much for your attention.